All right. So we're going to talk about sleep disorders first. Oh, I probably should put this on play mode. Okay, Snodgrass did this one. She's the one that teaches psych in the fall. I mean, in the spring. I'm sorry, this is the fall. I don't know my months. Okay, so we've got definitions of sleep. I really don't think this is important. You know what sleep is, but there's like a conceptual and physiological component of sleep, but they still don't really 100% know what it is. You can be a sleep doctor if you want to. There's criteria seen on EEGs, EMGs, and EOGs, just so we know. Okay, so there's REM and non-REM. So our non-REM is going to be that dreamless sleep. It's about 15 minutes of body repositioning and normal muscle tone. And during this, there's going to be amnesia. We have no dreams. So know that it's no dreams and you can move. So if you think about it, and we'll get into like the ins and outs, but you know when you're like falling asleep and then you feel like you're falling and you jump. So we're in non-REM. REM is where dreaming occurs. So you wake up and you remember your dream while you were in REM. You have flaccid limb paralysis, so you can't move at all. And then, but you do have rapid eye movements, and that's what REM stands for, rapid eye movement. Predominantly horizontal. Oops. And then the autonomic nervous system is going to increase as well. Sleep phys is going to be an alternating sleep stages. So we've got the non-REM and REM. So you fall asleep and you progress through your non-REM all the way to REM. So it goes like non-REM 1, 2, 3, 2, 1 REM. So I think we'll see some charts, and I think it makes more sense there. Here we are. So you get 4 to 6 cycles a night of non-REM and REM. So here we are awake, and then we go into our non-REM stage 1, and we get deeper and deeper into sleep, where we get to non-REM stage 3, right? And then we start going back up to 2, to our level 1, and here we are at REM sleep. So REM sleep is like almost at awake, it's close, but that again, that's where we dream. We can't move. And then you do this cycle again where we go into non-REM 1, 2, 3, 2, 1 REM. Maybe we wake up, check our phone. So our first third of the night is usually non-REM, and our last third of the night is going to increase into REM, and you can see how there's more REM at the end. Okay, so this is the important thing to know for the test, and all tests, including boards and like practice board questions. So we've got our N1, which is our light phase, and then we go intermediate, and then our deeper sleep. So what's important to know is that for N1, we've got our loss of alpha activity, but N2, like I really think that this is like absolutely 100% their favorite thing. Just know in REM 2, you have sleep spindles and K complexes. Remember that forever, because I don't know why people love to ask that question, but they really do. So if I were to ask a question on an exam, I would say, what do you see on a EEG for non-REM stage 2? And you would literally put sleep spindles or K complexes, and that's it. So just know that. Like, I promise you that'll be a test question. somewhere in your life, if not Friday or Thursday on your quiz. Stage 3, it's going to be slow wave deep delta. Know that 3 is delta. So 2, we've got our sleep spindles, K complexes, 3 is delta. Remember it. Okay, now we look at all these pictures and we're like, what in the world is going on? I don't know. I really don't think this is important to know. I know that they included it and said maybe learn it or understand it, but I really don't think it's important. So I've never seen one of these pictures. I've never had to interpret one. I really don't think it's important, but we can see it's kind of straight and flat. With 2, we get these sleep spindles. So I guess this is what a spindle looks like, but again, I don't think it's important. And here's our K complexes. I don't know if these look like a K, maybe. Again, I also don't think it's important, but they're more jaggedy, so we're in a deeper sleep. And then these are like super jagged, so we're in 3. But again, I don't think this is important. Okay. So here's our non-REM, REM, and awake. So here's normal sleep, and here is REM. So we can see that, and then this is awake. So we can see it's pretty lit up, and it's super light, lit up during, awake time. So it's almost more similar, and then non-REM. Okay, just some terminology. Sleep latency. Anytime you see latency is going to be that interval of time between something. So between trying to fall asleep and actually 100% you're asleep. REM latency is between you first falling asleep and entering REM. Sleep latency is going to be the shortest in a med student that just took a test or was on clinicals for a really long period of time and they're super tired. Elderly, it's going to take a while. So sometimes you'll see usually women, you'll see they come in and they're like, I can't sleep. So sadly, we can't sleep as good when we're older. And then there are other things called like narcolepsy that we'll talk about, depression, sleep apnea, and so on and so forth. If you drank too much alcohol, withdrawal. So why do we need sleep? There's no proof, there's no like scientific proof that says that, hey, we have to have sleep. Although if you take a bunch of people and you deprive them of sleep, which is actually a study that they did, they took a bunch of 20-year-olds, deprived them of sleep, and watched to see what would happen. And by day 3, they were all psychotic. So sometimes in the hospital, you'll see people, and we've talked about this a little bit, they'll be like out of their mind. They don't know where they are. Like they're wild and they're not sleeping good. And so same thing, it's important. We just don't know everything about it. So this ascending reticular activating system is responsible for regulating arousal and sleep-wake transition. Know that orexin, hypocretin, promotes wakefulness. I think that's probably the most important thing to know on the slide, honestly. But I know that when we talk about drugs, orexin, hypocretin is important. So know that that helps you wake up. That might be important. Okay, circadian rhythm and melatonin. You might have heard of people taking melatonin. Maybe you have before. So we've got this like internal clock that tells us to get up. It's set by our suprachiasmatic nucleus of the hypothalamus, which I think was like important for neuroanatomy. I think that we learned that and had to know that for that. I don't think it's as important now. And you sort of have that time, like let's say every day you get up at 6 a.m. and then it's Saturday and you just automatically get up around 6 a.m. So you can see that sleep wake cycle at work. And when it's dark, your body is sort of telling you to sleep versus light. Okay. The pineal gland is responsible for the production of melatonin. That's probably important. And darkness promotes it. Okay. Lightness suppresses. So know that pineal gland produces melatonin. Circadian rhythm sleep disorders. Some could be like jet lag. There's that non 24-hour sleep wake type, shift work type. So like this week I'm working nights instead of days. So I might get a little bit, my circadian rhythm is probably going to be a little bit off next week because I'm not used to that. I'm used to working days. So that's what that means. Non 24-hour, I think they've got like commercials about it, they've got like new medicine or something for blind people who don't experience light and dark. They could have like circadian rhythm sleep disorders because they don't have that, they don't know the difference, or they can't experience the difference like the rest of us do for their pineal gland to produce melatonin. So some of these are important to know just because in a question, you might know everything about the question and they throw one of these words in here. And I can attest to this for like the board exams are really bad about this. Like, all of the stuff and then they throw a big word and it's like, what in the world does this mean? Or they throw in a test and you've not learned it before. You've never seen it anywhere in any board things or any lectures. And it can throw you for a loop. So just sort of know what these mean. Like dysomnia is a disorder from insomnia or daytime sleepiness. Hypersomnia, too much somnia, so too much sleepiness. Daytime somnolence. Insomnia, they think they can't sleep enough, inadequate. Parasomnia is sort of a movement or behavior. I think of like paranoia, it's sort of a behavior thing. So parasomnia, behavior, movement during sleep. Okay. DSM-5 is has like some of these characteristics under here. I just really don't think that you need to know that like insomnia disorder or narcolepsy is a type of dysomnia. Like, I don't think that's as important. Always think about sleep apnea as a differential in the back of your mind for many things, especially when we go into respiratory and cardio. It can affect a bunch of stuff. It affects our heart and breathing. We already talked about that. Okay. This 100% will be a question on your exam. So you've got this patient that comes in and they can't sleep. And they're saying, Doc, what do I do? And the answer choices are going to be give them some drug. Let's say give them melatonin, give them a benzo, give them a non-benzo, which we'll talk about, one of the Z drugs. Get them a sleep test, polysomnography, or sleep hygiene. Tell them to not force sleep, avoid caffeinated beverages after lunch, no alcohol at bedtime, stop the smoking, turn off the TVs, get rid of the phone, unplug, dark room, don't be studying or snacking or doing anything pretty much besides sleep in your bed, which I'm terrible at because I like to study or read or, I don't know, watch TV in bed. But those are all bad for sleep hygiene. So don't take naps. That is going to be your answer. Make sure you go to sleep hygiene first. Always tell them to do that before we give them drugs or do testing. Make sure that all the stuff is avoided, or all the bad stuff is avoided, and they get good sleep hygiene. It seems easy, but they'll try to trip you up. So just make sure that you answer, make sure they get the sleep hygiene thing first. Okay. Hypersomnia, narcolepsy. So this is the big sleeping disorder, and they have this intrusion of REM into non-REM. So it's going to start between adolescence and age 25. This happened to one of the students at DCOM, and it's equal among males and females. And basically, they have these four cardinal symptoms: chronic excessive daytime somnolence, which is not relieved by normal sleep. So, like, I went to sleep for 10 hours last night and I'm still really sleepy, and all of a sudden, I just fall asleep. Or you get this patient with cataplexy, which is a sudden loss of postural tone while awake. So they're just talking, and in the middle of the sentence, they just almost become paralyzed. And then also they may have like a positive, they may lose postural tone and like start laughing, which is odd. So think about like an and um, emotion and loss of tone with cataplexy, and that might key you into narcolepsy. Sleep paralysis, they're awake, but they can't move. And it's not just like, occasionally it's like you wake up and you're like, I don't know where I am, even though like you're in bed and you're fine, or you're on the couch or something. But, and you're like, I just can't move. But this is like all the time. And then hypnagogic hallucinations are going to be like auditory visual hallucinations as they fall asleep. So these people who have narcolepsy are going to go into REM in the middle of the day. So they may like all of a sudden they're fine, and then they're like immediately going into REM sleep. And then they wake up multiple times a day. So they have a shortened REM latency, so they go into REM quicker, and they don't go through that progression of non-REM 1 through 3. So know that the mean, I would probably know this for maybe the quiz, mean sleep latency is going to be less than 8 minutes. I would like just, whoops. I would know this definition. A mean sleep latency less than 8 minutes plus 2 or more sleep onset REM periods. So REMs during naps. So less than 8 minutes to get to sleep plus 2 or more REM periods during naps. Because it might be something that's like they tell you they get a polysomnography, and their REM, it takes 10 minutes to fall asleep. Well, that's greater than 8. So let's say, or if the question said, well, it takes 6 minutes to fall asleep, and they had three REM periods during their nap, then that would be narcolepsy. And then it might ask like, okay, so now I know it's narcolepsy. Okay, what am I going to treat them with? And we'll get there. So just make sure you know this criteria, and then they'll like mess up the minutes or the amount of REMs, and see if you know how to identify narcolepsy. Okay, treatment. Here we are. Modafinil, or armodafinil, but probably modafinil. It's going to be a stimulant during the day that affects hypocretin orexin. So remember I said that that's probably important to know. That's because of this drug. So remember, hypocretin orexin is going to be our wakeful peptides. So this is going to be a stimulant, unlike some of our stimulants that we'll talk about in the spring for ADHD. But this stimulant, it affects that hypocretin orexin. And it's first line because it has a low abuse potential. So sometimes when we think about stimulants, we think about that they've got high abuse, but this one does not because it affects that hypocretin orexin. So no, so we remember less than 8 minutes sleep latency, 2 to 3 times of REM. We're going to treat them with modafinil. It affects hypocretin orexin. Amphetamine derivatives, they're going to have high abuse potential. Methylphenidate derivatives, they're both increasing dopamine release, and that is highly addictive, as well as dextroamphetamine, and it can help reduce cataplexy. So I would know that for like dextroamphetamine. Okay. Sedatives and at the hour of sleep. So if this patient is on modafinil, still having trouble at the hour of sleep, then they can get sodium oxybate. It binds to GABA B receptors to affect norepi and dopamine transmission. And but it is very, very abused. It's known as a date rape drug. It's classified as a narcotic. So, and it's like you have to order it from, I think they told us, like you have to order it from a special place and it gets shipped to the doctor's office for you to be able to pick it up if you get sodium oxybate. Like you can't just go to the pharmacy and get it. Like it's highly, highly regulated by the DEA. So there you go. But this is like big dog. This is what everyone with narcolepsy gets. Okay. Parasomnia, restless leg syndrome. So we talked about restless leg a little bit last week. It's this feeling that you have to move your legs, you get that crawling sensation. Anytime that you hear crawling sensation, feel like you have to move a lot at night, that's going to be restless leg syndrome. Know that it affects the dopamine system. It can also be an iron insufficiency. So if somebody is having restless leg syndrome, it's important to get to check their hemoglobin and hematocrit. If we know it's low, think about to like heme exam 1. If that's low, and then we see that they're like hypochromic, and we're going to order our ferritin and our transferritin and our TIBC, and we see that they're iron deficient, then of course figure out why. Like go fishing, figure out like do they have a GI bleed or something, but then replace it, and maybe the restless leg syndrome goes away. If not, and they don't have that problem, then it's probably more of just this dopamine receptor dysfunction, and you're going to treat them with ropinirole or pramipexole, and then sometimes calcium channel ligand drugs like gabapentin. Okay, breathing disorders, obstructive sleep apnea. So criteria is going to be 5 apneas per hour of sleep. So you usually, to sort of screen this, you ask a significant other or somebody they live with, does this person stop breathing in the middle of the night? Do they snore? Do they fall asleep at the stop, or like you ask the person, do you ever fall asleep at the stoplight? Things that go along with it is going to be like hypertension, mood disorders, like all of the heart stuff, stroke, AFib, diabetes, all of that. And then you can also get a polysomnography with 15 plus apneas. And severity, of course, is like going to be based on how many times they're apneic. it's a stop of airflow for 10 seconds without respiratory effort is going to be our central sleep apnea. And then 5 events per hour on polysomnography. So it's going to be less common than our obstructive sleep apnea. So usually it's going to be, the answer will be obstructive sleep apnea. So treatment for both of these would be our CPAP, continuous positive airway pressure, continuously pushing those lungs open and giving oxygen at night. And you'll learn more about it when you get to cardio, but it's good to know now because they definitely could ask a question about obstructive sleep apnea, most likely. So stopping sleeping. Okay. Sleepwalking is usually in childhood and it's during non-REM. So know that it's not during REM, because if it's during REM, then they can't move. So, but during non-REM, they can. And know that it occurs in the N3 slow wave delta sleep. So I would know that sleepwalking, it's N3 delta sleep. And they don't remember what happened. Okay. Any questions before we flip to farm of headache, sleep, and dizziness? Okay. Good deal. NSAIDs and opiates. Oh no, I didn't know I had this on this. Okay, mild to moderate. Oh goodness. What is this? Okay. For mild to moderate attacks, and I didn't even know I have these blanks, so I'm sorry about that. Of headaches, NSAIDs can be used. Moderate to severe, I probably would not use opiates, but sometimes they're used in the ER for like rescue. It's more of an old thing. They don't do it as much anymore. Butorphanol nasal spray is an agonist at the K opiate receptors and mixed at the mu receptors. I feel like that was important for us, but we also had a different professor, so take it as you will. Okay, serotonin agonists are triptans. We had talked about that last week. So we've got our 5-HT1B and 1D agonist, and they are going, so they're working with serotonin. They're going to enhance vasoconstriction. So remember from physio, when we vasoconstrict, that's our alpha 1. We're going to be pushing. It's like pushing on a garden hose. If we push on a garden hose, we're going to have like stronger current of stream. We're adding a little resistance. So that's what these triptans are doing. So we can get blood to the site. We're inhibiting vasoactive peptide release and inhibiting transmission through second order neurons, but causing vasoconstriction and inhibition of vasoactive peptides. They're contraindicated in things that we don't want vasoconstriction in, like ischemic heart disease or uncontrolled hypertension, because if you think about it, that wouldn't be good. Prince metals, you'll learn about. It's like a vasospastic angina, and which can cause sort of an MI. So triptans would be really bad in that situation. And so just think of like heart things are bad. Heart things, high blood pressure, bad with triptans. Okay. Our ergos are going to be ergotamine and dihydroxyergotamine are going to be non-selective 5-HT1 receptor agonist, but they're going to be contraindicated more in more of that heart stuff. Also sepsis and pregnancy. So I would probably know pregnancy as well. I don't have it in red, but and you cannot combine it with a triptan or give it in like, so really like every part of the body, your liver, your kidneys, your heart, if you're pregnant, all bad with this one. Okay. And it can also cause nausea and vomiting because it stimulates that chemoreceptor trigger zone. So you may have to give them an antiemetic. So that's like you have to go on drugs to take this. I don't know. Seems bad, but it might help someone. It's a very potent vasoconstrictor, more than our triptans. So with ergotism, we're going to have severe ischemia, so cold, numb, painful extremities, continuous paresthesias, and decreased pulses and claudication. So it's taking it away from our periphery and pumping that blood up to the center of our body, to our heart and brain. Antiemetics and corticosteroids. So metoclopramide, cloprazine are going to be dopamine antagonists, and they can help with other drugs, like and help with nausea and gastroparesis, and occasionally used just as a monotherapy. But they may have like side effects. Okay. Beta blockers can be used as a prophylactic migraine therapy, especially if a patient has hypertension or heart disease. These are already used in those, so it can help with migraines as well. And verapamil also if the beta blocker is contraindicated. Antidepressants can be used as well as anticonvulsants. More prophylactics, triptans can work on serotonin and help, especially if they're in like this predictable menstrual cycle period. NSAIDs also, like if a patient has their period and they take it like a few days before that starts and they know they're going to get headaches, then that could be a prophylactic means as well. I'm just going to skip that miscellaneous stuff. Okay. Abortive therapy, NSAIDs, Tylenol, and then for tension headaches, and then prophylactic is again those antidepressants, and then also Botox. So getting it in those muscles and relaxing them that causes the tension headaches might help as well. Cluster headaches, we talked about the abortive therapy that was super important and really good to know, which is oxygen, and then triptans or ergos. Again, prophylaxis is not going to be like our migraines, which was beta blockers, but it's going to be verapamil, so our calcium channel blockers. Maybe lithium, it's got way too many side effects, or steroids, which also has side effects and you can't stay on forever. So I would know probably like calcium channel blocker for prophylaxis and abortive oxygen. Knowing that our neurotransmitter, I think like, let's see, we had to know that norepi, serotonin, and histamine are arousal promoting. GABA is going to be sleep promoting, and then orexin is orexin releasing, and adenosine is going to promote sleep as well. So know sort of which neurotransmitters promote sleep and which one promotes arousal. Note that orexin is also arousal promoting, and then sort of where they're located as well. It's probably important to know. So like raphe-nucleus is serotonin. I think that's probably the most important. Let's see if we got anything else. Here's a little more. The ventrolateral preoptic nuclei is going to work with GABA. feel like these are less important. We talked about sleep stages, benzos. So benzos should, there's like different thought processes whether they should be used or not, and sometimes they like fight out whether they should be used. Probably shouldn't, because withdrawal of benzodiazepines can cause a wakefulness, and also benzos are highly abused. We know that benzos promote GABA A and calcium or chloride channel, sorry, and can cause sedation and hypnosis, as well as anterograde amnesia. However, it increases sleep too, but decreases delta, which remember that's N3, and decreases sleep latency, but they withdrawal causes awakening and lack of sleep. Also, if they take too many, they can hypoventilate. And then you don't want to like decrease tone in people already with obstructive sleep apnea. So no benzos cause anterograde amnesia. Bad with COPD, bad with opiates, bad with obstructive sleep apnea, because they could stop breathing. Okay, the Z drugs. So a patient comes to us and says, what do I do for my sleep? Number one, fix their sleep hygiene. Then what do we do next? After they've done all that, let's get them a polysomnography and figure out why they can't sleep. Let's say that comes back completely normal. They don't have obstructive sleep apnea. They don't have restless leg syndrome. They don't have narcolepsy. Now, what do? They just have plain old insomnia. Now we go to the Z drugs. And so that's going to be our zolpidem, our Zalpilon. So what you probably have heard on TV, Ambien and Sonata. So these are non-benzos, but they act at the GABA A chloride channel. And they're just less effective as anticonvulsants as our BZDs. But they do decrease that sleep latency, so they have a quicker sleep onset. And again, careful with people with respiratory depression, and it again can cause amnesia. So don't also drink it with alcohol. And then Zalplanon. Totally said that wrong. It's going to have less of a half-life, so less of a hangover. But basically, all the Z drugs are sort of acting the same way. Sleep maintenance. Here's another Z drug. It's got a Z in it, S-zolpidem. Again, sort of works the same way, but it has less of that hangover, but it could have an unpleasant taste, and they could have like crazy behavior changes. And you can take it longer. Melatonin, so it acts at MT1 and MT2. So MT1 promotes sleep onset, MT2 shifts the timing of the circadian system. And our two drugs are going to be temelaton, so it sort of sounds like melatonin in it, and it's going to increase sleep by improving the circadian rhythm. And then Rimelton, again, sort of sounds like melatonin a little bit. I would probably know that one. I feel like this is the one that people talk about more or prescribe more. And it's going to be selective for MT1 and 2. It's safer. Trazodone is under our antidepressants at low doses. Serotonin, it's a serotonin agonist. And at, and it can help people prone to substance abuse, although I'm pretty sure that they also abuse it too. And then it can also treat insomnia caused by antidepressants. So our side effects are going to be hangover, alpha blockade, so again, bad in like hypertension, and orthostasis. And then also like Dr. Babos had us remember it like trazodone, because it can cause priapism. So, fun fact. Mirtazapine is going to be antihistamine and anti-serotonergic. So it's acting at 5-HT2 and 3. At low doses, it can be used for patients with depression and insomnia. Our amitriptyline, nortriptyline, doxepin is going to block histamine receptors and alpha-1 receptors and cause sedation. But it could cause cardiac problems in the elderly. So, not good. Okay. Orexin antagonist, which would be sorvexant. So it kind of looks like orexin in the middle of it, orexant. So it's Bilsamra is the on the TV name that you might see a commercial for. I think it's been a few years since they've had commercials for it, but it's a selective antagonist for OX1R and 2R receptors. Our remember orexin is going to wake us up. Our other time that we heard orexin was for narcolepsy with our modafinil. So our survexant is going to have adverse effects of sleep paralysis, somnolence, which we want, and then could cause suicide in higher doses. Again, here's our modafinil, and we've already talked about that. Know that it could be an adverse effect could be Stevens-Johnson syndrome or 10, which you'll talk about when you get to derm. But just know bad rash. If a patient gets like a terrible rash and they just started modafinil, then that would be a reason to take them off of that. Sodium oxybate, we talked about that. It works at the GABA receptors. It's like one of a last thing to go to because it is considered sort of as a date-rape drug. Cataplexy, we're going to go with venlafaxine or fluoxetine. So more of our psych drugs and antidepressants. Venlafaxine is going to work at serotonin and norepi, and fluoxetine is inhibiting reuptake of serotonin. So the antidepressants suppress REM sleep and cataplexy because cataplexy occurs at REM. Restless leg syndrome, again, we talked about ropinirole and pramipexole and how they work at the dopamine, they're dopamine agonist. Okay, epilepsy. So any questions after pharm? And I think I've got a sort of like a review sheet. Maybe I put it at the end for pharm. Okay, I'll keep going. So epilepsy is complex of symptoms in the brain, and it can be clinical or diagnosed by EEG. For the patient, it's more personal. It's important to know what the patient recalls before the event, during, and after, and know the duration and frequency, as well as how it impacts them. got a kid at school who's seizing multiple times, I mean, that could be a total, that could affect their self-image. Um, and, be like, well, I didn't get invited over to some party because they didn't want to have to deal with me because I seize. I don't know. Just know that it affects their whole life. Okay, so by age group, here's the most common. So for neonatals, congenital is they've got some congenital maldevelopment issue, and that's like the most common, as well as birth trauma and loss of oxygen to the brain, and then some others. Infancy is going to be the same, so congenital, trauma, and not enough air, as well as infection can be in there. Early childhood, one of the most common causes of childhood seizures are going to be febrile seizures. So if a child has one seizure and they have a fever, it's not a thing to worry about, which is kind of crazy to tell somebody. But it's not a worry if they've got a seizure. I mean, if they've got a fever, because it's because of the fever, not because of something else. But if they continue to have seizures, that's when it's a problem. Again, injuries, infections, traumas can also cause seizures in this age group. Childhood, 3 to 10, is going to be around that time of birth when they didn't have enough oxygen, anoxia, trauma at birth, again, infections and other disorders can cause this as well. Adolescents, 10 to 18, they don't know why. They just start having seizures and maybe idiopathic, don't really know. Trauma, like let's say they get a big blow to the brain, that could cause a seizure. And then always keep in the back of your mind drugs and alcohol. And then as we go to adulthood, not really sure why, trauma again, and then like neoplasms. If somebody all of a sudden starts seizing, which apparently happened to my grandma, she had a meningioma when she was 50, and she was fine. She was cutting hair and then just dropped on the floor seizing and found out that she had a big tumor. So that can cause a seizure. Your brain is not used to something pressing on it. It likes to be happy and have space. And then again, drugs and alcohol. Middle age, same thing. Now we're adding like vascular disease to the mix. Late life, it's basically going to be vascular. So stroke can cause it. Tumors can cause it, infection. Okay, so here's our parts of our seizure. So we talked about auras when we were talking about typical migraines, or our classic migraines, not our common ones. And this is what they experience before an event, and they remember it when the event was over. So they may not remember seizing, but they'll remember the aura, and they'll remember what happens afterwards usually. So they get this funny feeling. Maybe every time before they have a seizure, they get this taste in their mouth or like smell something funny. Maybe they see like wavy lines or flashing lights or hear something, and they know that it's coming on. Just like a person with a migraine might know they're going to have a migraine because they get these feelings, they get this aura. After the seizure, there's this portion called the ictus or ictal period, and this is really key in knowing that a person had a seizure. So you've got a patient that comes in and you're not really sure what happened to them, or you don't know if you're trying to figure out what's wrong with them. And it's important to know, like, they had some like weird event. If they have this ictal period, this really keys in that it's a seizure. Or post-ictal period, I'm sorry. But this ictal period during is our seizure. And it can manifest in many ways that I think that we go into more. So we've got this like convulsive activity, um, focal focal seizure, non-convulsive like staring, or repetitive behaviors. So, and then after the seizure is the postictal period. And usually, and I think there's probably a slide after that, but we'll just go over it now. It's where they're like super tired and lethargic, and seeing that, okay, this person had something weird, like they were just staring. Is it that they're staring? Is it that it's a psych disorder? Is it that they were tired? Or but now they've got this like super tiredness and they're sleeping, then that can key you into like, okay, they just had a seizure. So classifications, this is good to know to be able to identify our parts of a seizure. So partial is going to be focal local seizures. So a simple partial seizure is going to be that the consciousness is not impaired. So they don't lose consciousness, but there's going to be motor signs, sensory signs, automatic autonomic signs, or psych signs. So they may have just one thing that's off, but they do not lose consciousness. So that is a partial, simple partial seizure. A complex partial seizure is going to be one that consciousness is impaired. So that's what our complex. So simple, we have consciousness not impaired. We have complex, which consciousness is impaired. So, so we have that simple partial onset where they have one thing going on, they don't lose consciousness, and then all of a sudden they do lose consciousness, and that's where we get to our complex. And they may have, some of those partial features like a motor disturbance or something like that. But know that consciousness is impaired when we call it complex. And then we've got some other ones. So absence or absence seizures is I don't ever hear it called petit mal, but is when they're staring off into space. So they're staring off and you keep repeating, Billy, 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 look at me, Billy. And Billy is just looking at the TV screen, and like you can't get him to respond. This is common age group of teenagers or childhood seizures. So know that one, absence. Tonic clonic is the one that you think about when you think about seizures, is that grand mal seizure. And that's where like a patient is like in the floor, they lose tone and then they contract and they're like shaking all over, and they have that loss of consciousness. Myoclonic seizure is going to be muscle twitching, so it may just be an arm twitching, so that's a myoclonic seizure. Tonic seizure is going to be tone, so they're going to be stiff. Clonic is going to be jerking parts of the body. So our grand mal seizure is going to be that it is going between stiffness and jerking of parts of the body. And then atonic seizure, their loss of tone, they like fall to the ground. Okay, and it's affecting everything, so that's why it's generalized. So epilepsy treatment, we've got medicines and then also surgery. So if a patient fails multiple meds over a period of time, they may, usually they'll get an MRI of their brain anyways, and they may see a portion of the brain that maybe has it's just not working. So like the temporal lobe, for instance, and these seizures may respond to taking out that portion of the brain, or resect it, or cut the corpus callosum, or maybe place a vagal nerve stimulator. So this is what was described by a neurosurgeon to a patient. She said, if I've got a bad portion of the brain, if you think about it, it's like kids in the classroom. You got this bad kid in there. If he's poking the kid beside him over and over again, he keeps poking him and poking him and poking him. And that kid is a good kid. And, lets him poke him. And finally, that kid gets fed up with him and like punches the kid that keeps poking him. That's like the brain. So the reason why they take a portion of the brain out, because it seems like it's crazy. This bad part is like causing these seizures, and it's keeps seizing and disrupting the good portion of the brain. And if it keeps doing that, the good portion of the brain starts wanting to have seizures as well. So I thought that was kind of a cool way to describe it. Okay, other considerations. The older anticonvulsants can cause bone demineralization. And so you have to like monitor bone density. Some of them affect folic acid, so it's important to supplement with folic acid if they're going to get pregnant. And then some require routine labs like the CBC, liver, electrolytes, and drug levels, which we'll talk about in a little bit. Status epilepticus. So status means it takes a while. So this is going to be a seizure lasting greater than 5 minutes. And it's going to be that the seizures occur so frequently that the patient can't recover. This is an emergency, and this is when we need to push the good drugs. Tonic-clonic, the ones that we really think about, status epilepticus are the most life-threatening. But it can also be seen with like absence or simple complex. So what do we do? So if you're out in the middle of the classroom and you don't have the good drugs with you, you need to first make sure that you need to check your ABC. So airway, breathing, and circulation. And that's always important to, like a board exam question asks you, like, what should you do first? Make sure that they've got a good airway, they can breathe, and they've got circulation. And then number 2, we need to get an IV in them so that we can get labs. Are they on drugs? Is this what's going on? Is like their blood sugar 14? Should we give them glucose? Is that why they're having a seizure? Or, and then also it's, for drug treatment. So we're going to administer lorazepam or diazepam, and you don't need to know doses. And then for refractory, which just means lorazepam, diazepam, or benzos aren't working, we'll grab phenytoin or phosphophenytoin. Other medications, if that's still not working, we're going to grab a barb instead, like phenobarbital. And then if that still doesn't work, you may have to put them under general anesthesia. So more definitions to know. And I think this sort of goes with MSK as well. But we've got peripheral neuropathy. So it is a dysfunction of the peripheral nervous system. Neuroneuropathy is going to be a dysfunction of a nerve cell body. Polyneuropathy is going to be a dysfunction of multiple nerves. And then mono is a single nerve, usually because of entrapment, which this lady was like, you guys could have honestly like seen her and treated her. You guys have enough knowledge with this patient I saw this week. She was sleeping funny. She put her leg sideways and entrapped the common fibular nerve. And so she had nerve entrapment. So she had a mononeuropathy. So basically told her, don't do that again. And your feeling will come back in a few days. So here's some crutches until then. So pretty cool. Okay, mononeuritis multiplex is going to be multiple nerves, but different limbs at the same time. Radiculopathy is going to be an abnormality at the nerve root. So usually like when we think of a radiculopathy, it's going to be like back pain that radiates down the leg. So the nerve root's affected. Polyradiopathy is going to be affecting multiple nerve root levels. And then radiculopathy, neuropathy is going to be multiple nerve roots and trunks. Okay, so we've got axonal and demyelinating. So our demyelinating we've already talked about, and that's going to be like our MS or like Guillain-Barré syndrome, and it's that delayed conduction. And axonal is going to be affecting the axon itself. So diabetic neuropathy is going to be affecting, it's the most common neuropathy, and it's affecting, it's a peripheral neuropathy, sorry. And usually affects like, it's called like a glove and sock and glove pattern. And so it's affecting hands and feet. Here's how to classify. Skipping that. Okay, already said that. And then Charcot-Marie-Tooth disease is going to be a demyelination and remyelination. So it'll result in a thickening of nerves, and the nerves are so thick and enlarged that you can actually feel them. However, so the way I remember that is like sort of weird, but it's like if a nerve becomes really thick and it's got that thickening and like it's like demyelinates, remyelinates. It's sort of like, I don't know, like somebody chewing on a nerve is what I feel like it would feel like if you felt it. It would be like, you know, somebody gnawing on it. Like if somebody gnaws on something like a corn on the cob, and then you like feel it, it would sort of feel bumpy. And so I think that that's what sort of these nerves would feel like if you felt it under a person's skin. So that's how I remembered it. It's kind of weird. Anyways. And then also they're going to have this pes cavus deformity of the feet, which is like, I don't know, like it. I don't think I can get my foot around here and try to show you, but it would be sort of like this, like that their feet would be. And knowing with this myelination, demyelination, the conduction is going to be slowed down. And they may have other features like scoliosis, contractions of wrist as things progress. And of course, reduction of like sensation. Oh, here it is. Here's our pes cavus. So like if they show you this, you might know it's Charcot-Marie-Tooth disease, or yeah, type 1. So diagnosis is made clinically. Type 2 is going to be autosomal dominant transmission. It's going to be less symptoms, and it's usually in a later decade of life, the second decade of life, and progression is much slower. Behçet-Sautas disease is going to be hypotonia, atrophy, weakness, ataxia, and thick lip pouting mouth. So I think of, I don't know, Dejournay. I think of like somebody like pouting. I don't know how to remember that, but it sounds like a fancy name, and like some woman didn't get her way, so she's pouting. I don't know. Guillain-Barré syndrome, you guys learned that in micro, and that goes along with Campylobacter. So know that it is a medical emergency and needs to be recognized early to prevent morbidity and mortality. So know that it is an ascending muscle weakness. So a lot of these muscle weaknesses are descending. This is an ascending one, and it can affect cranial nerves and lead to respiratory failure. So that's why it's a medical emergency. Campylobacter, here it is. Viral infections, occasionally, once in a blue moon, it could be caused by like a vaccine, just like a person's immune system reacting to it. Stressful things like pregnancy surgery, but it's often idiopathic. Diagnosis with a lumbar puncture, and you see elevated protein but no cells, and this, as well as the clinical history and physical. Treatment is going to be supportive care, make sure that they can breathe, monitor their vital signs, make sure they're not in pain, but also when it gets bad, IVIG or plasma exchange. Don't give steroids. Chronic inflammatory demyelinating polyneuropathy, CIDP, is going to be a autoimmune disorder characterized by weakness and sensory loss. Usually begins in the lower extremities. So we see this onion bulb formation on a nerve biopsy. And then again, with a lumbar puncture, we get the same thing that we got with Guillain-Barré, elevated protein with no cells. So here we are in this onion bulb formation. With this, unlike Guillain-Barré we treated with IVIG and plasma. With CIDP, we're going to treat with corticosteroids, and they're super helpful in this. For exacerbations, you can use plasma exchange and IVIG. Trigeminal neuralgia. This was important for us, and I think it was really important for boards. So our clinical presentation is going to be somebody that's chewing, and or they get this, like, they walk outside, it's winter, they get this cold burst of air, cold wind to the face, and then all of a sudden they get this electric pain coming from like the ear, right in front of the ear, and it's going down one or all of the trigeminal nerves. And between the attacks, this lightning sensation, they feel this dull, deep ache. So it is a focal demyelination of that trigeminal nerve. And you treat them with carbamazepine. So if you get something about the electric sensation, or they were chewing and then they felt the sharp pain on their face, 100% they will ask you the treatment, and the answer is carbamazepine. There's all these other answers, but like the answer will, or all these other medications, but the answer is going to be carbamazepine. That is our number one go-to drug. Facial nerve palsy, so Bell's palsy, is going to be a unilateral facial weakness. They may have ear pain, or they may have tearing, or they may not be able to completely close their eye, or they can't close their mouth, so they're going to be drooling on one side. Know that it's just affecting their facial nerve. They have no other neurological deficit, so it's not a stroke, because they don't have, like, the rest of their body is okay. So it could be inflammation, compression, or demyelination of that cranial nerve 7. It can be idiopathic, or it can be caused by herpes simplex. Again, we evaluate them. Glossopharyngeal neuralgia is going to affect our glossopharyngeal nerve. Triggers can be coughing, swallowing, yawning, cold liquids. Treatment is going to be medications used for neuropathic pain. And it can Again, we had talked about chronic paroxysmal hemicrania. Remember, it's at cluster headaches is one. It's cluster headaches is one of the types of chronic paroxysmal hemicrania, which we've talked about last week. Choroidonia is going to be a unilateral neck pain coming from like the jaw, face, and head. The pain is throbbing, stabbing, and it can last. There'll be tenderness and pulsations of the soft tissue along that artery, which is really common. And they're going to also have stroke-like symptoms. So you get like severe neck pain with stroke-like symptoms. You need to start thinking of carotid artery dissection. And so this is a medical emergency. They could get the neurologic symptoms could be things like an ipsilateral Horner's. It could be a disruption of blood flow. You may hear a bruit, so automatically need to act. It can cause by trauma, weakness. So make sure that you get MRI to look at it and see with contrast so that you can see where that if it's going through the media and dissecting. Postherpetic neuralgia is going to be associated with shingles, and this is a attack of a single nerve. After eruption of pain, they may have weeks to months of this severe hyperesthesia or like just this sharp stabby pain. So here's shingles, and this guy may have pain for months afterwards. So no, it's caused by herpes zoster, and it's producing that necrosis of the dorsal root ganglion. So treatment is going to be steroids, antivirals, analgesics, maybe a lidocaine patch, maybe like amitriptyline, nortriptyline are helpful. It's basically the same thing. Oh, sorry, this is not your professor, so just forget about that. But it's going to be back to epilepsy. So we've got discharges of neurons of the threshold for firing when it is reduced beyond the capability of the membrane threshold. So you can see here's failed initiations, and now it's beyond the threshold to cause that action potential and causing epilepsy. Tonic-clonic seizures, again, clonic is the shaking, tonic is tone, and GABA inhibition is lost. Absence seizures are going to be a burst of the T-type calcium channels. So I would know that because we're going to treat our absence seizures with these T-type calcium channel blockers. So adverse effects of our anti-epileptic drugs are going to be usually allergic reactions, skin reactions, weight gain, but not with our topiramate or ethosuximide. And then if they just stop cold turkey, then they could precipitate a seizure. And then there's lots of drug interactions. Phenytoin, barbiturates, primidone, and carbamazepine are huge hepatic enzyme inducers. And then estrogen is in like contraceptives, can be affected by induction. Know that valproate is an inhibitor. So these patients who want to get pregnant these drugs may affect, are like, a lot of them are teratogenic, and then also some are like make contraceptives not work. So make sure you tell them they need the alternate means, like condoms. Okay, so there's that loss of hormonal, loss of efficacy of the oral contraceptives because of that induction of estrogen metabolism. And then again, like they're teratogens. So valproate won't interfere with contraceptives, but it's really teratogenic. So it's important to know. So valproate, they can take contraceptives with it, and it's okay, they won't interfere. However, if they didn't take their pill and they get pregnant, then valproate is a really teratogenic, bad drug to be on for baby. Carbamazepine, we had talked about this one with trigeminal neuralgia, and it's blocking your sodium channels. And know that it is a enzyme inducer. I think that's probably the most important to know for it. Lamotrigine, also known as Lamictal, is a sodium channel blocker as well, and it also blocks NMDA release and calcium channels. Know that it can cause a rash, so it's good to go low and slow. So start the dose low, then titrate up. Phenyltoin and phosphoenoltoin, the side effects are going to be our phangatoin, so folate depletion, which is not good if you're having kids, allergies, so in Stevens-Johnson syndrome, nystagmus at toxic level, gingival hyperplasia. That was actually like a practice question I did. It was saying that this person has their gums are like growing over, and it was trying to like get you to know that they were on phenyltoin. Agranulocytosis, so low, they'll have like low white blood cells. That might be something to know. Teratogen again. Osteoporosis is important to know with phenyltoin and phosphophenoltoin. Induced enzymes, sodium channel blocker, which can lead to an arrhythmia. It's a zero order medicine, which is, there's not as many zero order ones. So I think that's important as well. So here it is. Zero order kinetics, small changes may lead to a disproportionate change in steady state. So if I take a normal drug that's first order kinetics, like remembering back to first year, if I take a drug and let's say I've got 1 milligram and the patient needs to go up. And so if I remember first order kinetics, if I give them 2 milligrams, that's going to double the plasma concentration. That is first order kinetics. Zero order kinetics, if I've got 1 milligram, let's say of phenyltoin, because we're just using easy numbers. If I have 1 milligram and I increase it now to 2 milligrams, I double the concentration, or I double the amount of drug. This may cause the plasma concentration to go up 3-fold. So really, even though I just doubled the drug, it could cause like a huge concentration and take them into toxic levels. So that's, remember, phenyltoin zero order. Topamax is a blockade of sodium and GABA channels, and know that it's got a great side effect of weight loss. So people on topiramate may lose weight, which is good for lots of patients. Because a lot of these drugs make you gain weight, but topiramate is one that doesn't. And so if a patient is already overweight and they are having seizures, this might be a good option. And combined with phentermine is going to be Qsymia, and that is a weight loss drug. Okay. Valproate and benzos act at the GABA channels. And know that thiamine is important with those. Okay. So our benzodiazepines, so when we're talking about seizures and breaking seizures, it's important to know ones that do that are active metabolites. There's some that go more through the liver and can accumulate. So if a patient comes in and they've got like a liver issue, or like we don't even know what's wrong with them really. Let's say they're like a big time alcoholic, or they have cirrhosis or something, or we just don't even know their medical history. We don't know if they have any liver problems. Good benzos to use are going to be our other than liver ones, or our OTLs, which also means oxazepam, other. Then is going to stand for temazepam, or L, liver, is going to stand for lorazepam. So know that oxazepam, temazepam, and lorazepam are ones that do not go as much through our liver and cause and undergo conjugation. So these are good drugs for seizures, or like of the benzos to grab. These are ones that we don't have to worry so much with people with liver disease. T-type calcium channel blockers. So we talked about that our absence seizures have the activation of T-type calcium. So we're going to block T-type calcium through ethosuximide is going to be our like go-to drug for absence seizures. Valproic acid and zosamide are going to be other ones as well. So ethosuximide is going to be what you grab for absence. So they're staring at a TV screen, you can't get them to talk, then all of a sudden they're tired afterwards. This patient should be on ethosuximide, and it can cause weight loss as well. So another thing is, like with the weight loss, if a patient is like anorexic, or they've got a really low BMI, then a weight loss drug is not what we should grab. If they already have a weight, if their weight is too low, that could be a problem as well. 2 more slides. Depakote is going to be our valproic acid, valproate, or dalvalproex. And it has many mechanisms. We are going to block calcium, sodium, and increase GABA, block NMDA, and inhibit histone. So its use is pretty broad spectrum. Like, we're blocking everything. It causes minimal sedation, bad parts, weight gain, hepatotoxicity. It's a teratogen, and it could cause pancreatitis. So it also causes many drug interactions because it's inhibiting the metabolism of other drugs. So valproate is the most teratogenic. It is not going to reduce the efficacy of contraceptives because it's not an inducer. So even though it is the most teratogenic, it's not going to hurt the contraceptive management. So know that. So here is my last slide. That is sort of a overview of everything. So looking at, when they have a seizure, the first thing to break is to grab a benzo. The good ones to grab, other that don't go through the liver, for our benzos are going to be oxazepam, temazepam, and lorazepam. Let's say if they've got a history of cirrhosis or something. If you need to supplement B6 with an anti-tuberculosis drug like isoniazid, and replace thiamines in chronic alcoholics. Adverse effects of most of these drugs are going to be weight gain. Know that if they stop it, all of a sudden they get a seizure. They could have a skin reaction. Drug interactions, valproate doesn't interfere with contraceptives, but all of the rest will. But know that it's very teratogenic. Phenytoin, barbiturates, primidone, and carbamazepine are broad hepatic enzyme inducers. And so here's our drugs. Broad spectrum is going to be our topiramate and valproate. Renault, it inhibits the metabolism of other drugs and helps prevent reoccurrence. Generalized, partial, or absence only is going to be our carbamazepine, are going to use for trigeminal neuralgia, and know it's an enzyme inducer. And then our phenytoin, it's got our phangatosin. No, it can cause like agranulocytosis, gingival hyperplasia, osteoporosis, and know that it's at 0 order kinetics. So we doubled the dose. We got disproportionate changes in the steady state blood levels. So that's like all the drugs in one page. I think that's it. Any questions? Thank you. If you need anything else, tell me this week and I can make it happen. And good luck on your test or your quiz Thursday, test Friday.